Christy, good to see you again. I think we are back here now to talk about Part 2, right?
Yep.
We're going to presume that everybody has been through Part 1. They understand how to prescribe, monitor, and adjust hormones. But holy cow, what happens if a patient walks in and they had breast cancer 3 years ago? What do?
And that's going to happen, you guys. The more patients you see, the more experiences you're going to have. And when you come to Part 2, the research on the randomized controlled trials is there for these breast cancer patients. But you leave Part 1 and you're totally equipped, ready, Monday morning ready. But when these nuances come in that you have to adjust and you have to do different protocols, that's what's covered in Part 2. How would you actively work with somebody who had breast cancer? Or how would you actively work with somebody who's a cancer survivor? Those type of things are discussed in Part 2 with confidence, so that you can feel confident in still offering them some relief of their symptoms.
Because the reality is the protocol changes.
The protocol changes. It absolutely changes.
And this is where Parts 2, 3, and 4 come in handy, because now we start to talk about different disease states and how what you prescribe is going to be different.
And they're complicated cases, right? They're not cases that are simply straightforward. They're complicated cases that require a lot more thinking and a lot more in-depth literature, which is what 2, 3, and 4 will offer you, so that you have that confidence to treat those patients the best way possible.
Yeah.
And get the best outcomes for those patients as well.
And I think cancer is like the most complex. So
It
how many
is.
hours do we normally spend on that?
Oh, well, in Parts 2, on breast cancer alone, probably 6 hours. Then prostate cancer in Part 3 and 4, another 4 hours at least. And so really important, but also all the benefits in these hormones in preventing these cancers in the first place, which is what we all want, those benefits of it.
Right. I think another big thing that he talks about in Part 2 is PCOS.
Yes.
Right? And I know the underlying statement is assume everybody has it until proven otherwise. And that's a big deal. That
Yes.
affects a lot of women.
Mm-hmm.
So talk to us a little bit about what is PCOS and how do we help people?
So since, as Dana mentioned, that PCOS is the most common hormone disorder in women, if you assume all women have PCOS until proven otherwise, you won't miss it, and that's the big thing. You have skinny PCOS, and you can have a traditional-looking PCOS patient, and I think that's where most providers get hung up on, is that they don't look PCOS, or they don't have those symptoms or the history of a PCOS patient. I'm PCOS. And I didn't really fit some of those symptoms. However, when you learn more about PCOS in these courses, because it's so detailed, all of a sudden these patients start rising to your mind of, oh, I could help this person, I can help this person. It's so entertaining and rewarding when these patients come back to you and say, you were the only one that helped me feel better. You're the only one that understood, or you were my only hope, which is always heavy for the provider. But the difference that you make in these PCOS patients' lives, we're talking about fertility, we're talking about miscarriages, we're talking about postpartum depression, and just life-saving treatments that help these patients with these hormonal deficiencies. And PCOS is so common, and everybody thinks that when you have a hysterectomy or you go into menopause that PCOS goes away, but it doesn't. It gets worse, and I'm living proof of that.
I think that's great. I think the more we know about it, why do they call it PCOS anyways? Is it really an ovarian problem?
No, it's not. So it's kind of a misnomer. It needs to be renamed. The ovaries are an innocent bystander that gets ovarian cysts, but not all PCOS patients have ovarian cysts. So they really need to rename it. It's more of an endocrine disorder related to the thyroid than it is to the female organs, but it does get blamed for that. I think PCOS is probably one of the most complex things you'll learn about, but also the one that makes the biggest difference. Well, I'll take that back. They all make a big difference. But PCOS to me was a light bulb that just flashed on in my mind of thinking, oh, we could help this patient and this patient. And just the protocols you learn at WorldLink Medical really are rewarding and really are fun to see those patients improve and make differences in their lives and have babies and not miscarry and not have postpartum depression.
Are there any other symptoms of PCOS?
Oh, yes. How about fatigue? How about depression? How about anxiety? How about missing your periods and your cycles? We're talking about weight gain. We're talking about, infertility, as we mentioned. But yes, there's tons of symptoms of PCOS that people miss. It's not just the bearded lady with the acne, but there's traditional people walking around that you would never guess that are PCOS suffering, that you can make a difference with.
And imagine if you become an expert in treating PCOS, and so many women have it, you'll be the talk of the town.
Well, that's what we talked about with Herman Pang answering all our questions. He, cardiovascular surgeon turned PCOS expert, right. And he can't there's too many people climbing in his doors, and his practice is successful because he's so knowledgeable about it.
That's awesome. All right, everybody, we hope to see you at Part 2. Thank you.